All right. Hello, everyone. Welcome to Med-Surg II HESI review sessions. So in today's session, in today's recording, I am going to cover the Med-Surg I content. Obviously, I cannot go all over everything in Med-Surg I because there are so much that we have learned during the semester, but I was able to condense and prioritize what I think you guys should know first. I do really recommend you guys come back and revisit your own note and make your own study guide and study from it, and then kind of pay more attention in the topic that I will going to share today. So talk a little bit about Med-Surg II HESI. It will contain a lot of the Med-Surg I content. So for that reason, this session was created. So without further ado, I'm going to go ahead and get started. I got a little fancier today, so I changed the background to this smart looking thing, but let's go ahead and get started. So this is the attendance QR code. Please scan the QR code so that people know that so that the deans or like my manager knows that there are students who are attending the session. Okay. Okay. Right. So very first thing from Med-Surg I that you guys need to know is the lab. Just remember all these lab guys. These are the important lab that we need to know. These include white blood count. If less than 4.5, patient not be able to fight infections. If more than 11, patient has an infections. Okay, white blood count regular normal range is 5,000 to 10,000 normal levels. Hemoglobin is 12 to 16 for a woman and 14 to 18 for men. Notify MD if hemoglobin is less than 9. Okay, give me 1 second. I pause recording. Okay, so for the hematocrit level, the 36 to 48 is for a woman and 42 to 54 is for men. So this hematocrit ACT is going to be in percentage, okay? So it will tell us the patient has enough circulatory blood. Red blood cell is 4.5 to 6. Platelet count is 150 to 400. Platelet count determine the clotting, is patient able to clot or not. So if it's less than 100,000, we notify the doctor. So 150 to 400, these are in thousand, okay? And check for Lovenox. What that means is before we inject the Lovenox medication for the patient, we have to make sure that their platelet count is more than 100,000. Next, we have BUN and creatinine. These are to evaluate the function of the kidney. BUN 10 to 20, or in Professor Lanasa, is 8 to 25. Creatinine is 0.6 to 1.3. Kidney function is compromised. The higher the number, the worse the situation of the kidney is. Okay, so high level BUN, high level creatinine, meaning that the kidney is not in good shape. And what will happen, we'll discuss in later slide. Okay, next we have potassium. Potassium 3.5 to 5. Potassium is really important for cardiac function. Out of range, too low potassium or too high potassium, it can cause a certain dysrhythmia that can be lethal to the body. So that's why we have to make sure that potassium is always stay within normal range, 3.5 to 5. Calcium is like 8 point something to like 11 point something, but for HESI purposes, it just remember it's at 911. So calcium, call 911. Okay, sodium is 135 to 145. Potassium is 3.5 to 5. Magnesium is 1.5 to 2.5. So how I remember it is Maggie is 1.5 to 2.5 years old. Okay, chloride is 98 to 107. All right, PT, INR, these are important as well. These are the time that it takes for the blood to clot. So the higher the number of the PT or the INR, the longer it takes the patient to clot. And the lower number of the PT and INR, the faster it makes the person to clot. So low number patient will be at risk for DVT clotting issue, DVT and stuff, and then a too high number, the patient at risk for clotting issues. They don't clot as fast and they can at risk for bleeding. So regular range of PT is 11 to 12.5. Professor Lanasa said, remember, it's at 9.6 to 11.8. INR is 0.8 to 1.1. If the patient is on Coumadin, which is the warfarin, this is the anticoagulant, the therapeutic range of it is 2 to 3. So always together, check for Coumadin, and warfarin. So what does this mean? So INR, the regular normal range is 0.8 to 1.1. So when the patient is prescribed Coumadin, we give them the Coumadin medication. The INR therapeutic range should be in 2 to 3. If it's higher than 3, it means that the medication is too strong or too much medication. If it's less than 2, the medication is not effective. They have to give more medication. Okay. All right. So a little bit about operation. So we talk about pre-op. We have to make sure that every operation, we need to tell the patient to empty their bladder before surgery. If the patient take diuretics, we need to draw the potassium level before we do the surgery. The reason is because a lot of diuretic are potassium wasting, so they can have a low potassium level, which can affect their heart and can cause arrhythmia or dysrhythmia during the surgery procedure. That's why we need to draw potassium level prior to the operation. If patient take G and E's or blood thinners, need to notify MDs. G and E's including glycol, ginseng, ginkgo, or vitamin E's, or any kind of blood thinners, anticoagulants, aspirin, for example. We need to notify the doctor to tell them that the patient take it prior to the surgery. So anticoagulant blood thinner NSAIDs, G and E's also must be off 72 hours to 1 week before the surgery, because these stuff causes the blood to be very thin. It puts the patient at higher risk for bleeding, and during surgery, the doctor is going to cut the patient open. They want the blood clot is in normal range. We do not want it. We do not want the patient to be at risk for bleeding, right? Next, we have aspirin, Coumadin, Plavix, Aleve, ibuprofen. These are NSAIDs. And what does NSAIDs cause? These are not. These are NSAIDs and also blood thinners. So all of these medication must be off 72 hours to 1 week prior to the surgery. Herb, like I said earlier, the G's and the E's, ginkgo, ginger, glycol, ginseng, vitamin E, vitamin G, and certain oil. So these put the patient at risk for bleeding. So kind of remember the G's and the E's and this medication. All right, a little bit about informed consent. I know these are really basic stuff. You guys might think that you guys know. So I'm sure that you guys know it. So I'm just going over it so that we have the better understanding. Informed consent, surgeon obtain consent, explain procedure. Nurse obtain signature, witness, make sure patient understand and inform. Nurse does not obtain the consent. We obtain a signature. So it's gonna be an easy question on HESI. So if it coming up about informed consent, please do not miss it. Nurse does not obtain consent, and surgeon does not have to obtain a signature. The surgeon only need to come and explain the procedure and stating that he is going to needing to obtain the consent, whereas the nurse will wait there and wait for the signature. All right, Malignant hyperthermia. This is a condition where it happens during the surgery, especially when the patient is receiving anesthesia. So it is often a reaction to an anesthesia agent. The most common is the succinylcholine. This anesthesia agent always often associated with malignant hyperthermia. So it increases carbon dioxide. It causes tachycardia to the point it's like more than 150 beats per minute, which is really high because the regular is 60 to 100. Increased pulses, muscle, tachypnea, fever, late finding is temperature rises. So if the patient is already have a fever, that means that it's late already. Inability to regulate calcium. Nursing management, dantrolene, calm the patient muscle, lidocaine, calm the patient hurt. Ice, cooling blanket, decrease external temp, give 100% oxygen. It is a genetic factor, so it's not autoimmune, it's not acquired, it is genetic. So history of family have issue with anesthesia. So if the patient coming in and they have a history, they have family have a history of issue with anesthesia, we need to make sure to use the one that they are not allergic to. So the patient still can have surgery, but they just need to have a surgery with another anesthesia, and more precaution are in place. Post-op complications. So, all right, so these are important part of the very first week of Med-Surg, right? Med-Surg I. So anytime 0 to 24 hours post-op, so they finish the procedure. So anytime between when they finish the procedure up to 24 hours, this is immediately post-op. So they are at risk for excessive bleeding, which can lead to hypovolemic shock, sign symptom, pain at incision site, increased heart rate, low blood pressure, weak thready pulse, diaphoresis, decreased urine output, pale, cyanotic, high pulse, shortness of breath. Check H&H, hemoglobin and hematocrit to see if the patient is bleeding or thirsty. This number will decrease. Nurse put another dressing on top of until surgeon comes and changes the first dressing. So after the surgery, the surgeon will be the person who changes the first dressing. The nurse never, unless the doctor tells the nurse to do it. Treatments: IV normal saline or half normal saline, legs up, heads down, Trendelenburg position. This will prevent especially low blood pressure. When patient have such low blood pressure, we put them in Trendelenburg position so that the blood can flow to the brain and preventing them from fainting or blacking out. Give them blood product and oxygen. If the patient is bleeding, the nurse put pressure on the bleeding site, put patient in Trendelenburg position, give fluid, blood, then call MD, okay? Day 1, after first 24 hours post-op. So this is day 1. Atelectasis is the most common. Sign, symptom, crackle, breath sounds, the end of inspiration and the beginning of expiration. Dyspnea, asymmetry chest expansion. This is alveoli collapse. Atelectasis is the alveoli that collapse. And you know, when we all know that the alveoli, when we inhale air, it's inflated and then it's kind of recoil a little bit. But in this patient atelectasis, these alveoli, they just collapse, and it's hard for them to inhale air in or get as much air as possible. This can progress to pneumonia if fluid sits in the lung. So anywhere if fluid is stasis or fluid stay there for a while, it can increase risk for forming bacteria and therefore lead to pneumonia. Treatment is teach inseminative spirometer, TCDB, turn, cough, deep breath, early ambulation, fluid, and position changes. Okay. Day 2, DVT, deep vein thrombosis. This is due to immobilization, bed rest. Sign and symptom, leg, calf pain, swelling, redness, weak pulse, less palpable pulse, prevent, we put SCDs on them, sequential compression device, mobility, early ambulation, compression shocks, blood thinners, Lovenox. Every time we give in Lovenox, must remember risk for bleeding, decreased blood pressure, high pulse, weak thready pulse, increased heart rate, and respiratory rate. That makes sense, right? When we have bleeding, the sign of the hypovolemic shock will be the blood pressure will decrease, the heart started to beat faster, so that it causes high pulse and tachycardia in order to promote the circulation to the rest of the body. And they have weak thready pulse because they are bleeding, so they don't have enough blood. Must assess for platelets, only give if platelet is more than 100,000. We do for Lovenox, we do sub-Q injection. We do it on the love handles, which is like 2 centimeters away from the umbilical, I don't know that word in English, but like the belly button, yes, the belly button. 2 inches away from the umbilicus. Oh, it's right here. Yeah, 2 inches away from the umbilicus. Day 3, infection is the thing that the patient most at risk in. At least 3 days for infection to grow. Okay, can be atelectasis that progress to pneumonia or UTI. Sign symptom: elevated white blood count, bad odor, purulent drainage, productive cough, crackle, sputum, fever. Sign symptom more include UTI, painful, sediment, and cloudy urine. So what does it mean? So if the patient have elevated white blood count, bad odor, purulent drainage, and productive cough, these are sign symptoms of pneumonia, meaning that the patient are developing infection to their lungs. Also, patients who are post-op, they also at risk for having a UTI develop an infection to their bladder, their urethra. So it causes painful, sediment, cloudy urine. White blood count often increase after surgery, body immune response, but if it is gradual increase, indicate infections. So if the patient is having fever and also an increase in white blood count, that indicate that the patient might having infection. But white blood count will be increased after the surgery because the body just been through so much stress. Treatment: antibiotic, fluid, and hand hygiene. All right, next we have wound dehiscence and evisceration. So wound dehiscence is basically incision is separated, and evisceration is the incision is separated, but the stomach content come through the wound. So say like the patient have a incision on the belly, right? So if they have a dehiscence, the suture, it just broke. But if they have an evisceration, the suture, it's broke, but also the stomach, the intestine, it comes out. We can see it protruding out. So mostly this occur with abdominal surgery. So we use an abdominal binder, pillow, and put the patient in low flower position. Okay, low flower position, and then the knee bent. So what we have to do as nurses is we cover the wound with moist, sterile, normal saline dressing, because moist continue perfusing the circulation. If it's not moist, it can get necrotic. Then call the doctor. Administer antiemetic to prevent vomiting, which could put the strain on incision. Instruct the patient to splint when coughing. Next, we have diagnostic study for diabetes mellitus. This diagnostic study usually used for patients with diabetes type 2 to diagnose whether they have DM type 2 or not. So the first is finger stick random blood sugar. If it's more than 200 and has diabetes mellitus symptom, the patient could have. This is not a confirmatory test, not. Repeat or do more tests to confirm. Next, we have fasting plasma glucose. The ideal range for this is 70 to 100. Fasting meaning that the patient does not eat anything 8 hours before the fasting plasma glucose procedure. So if the level is more than 126, they can have a diabetes mellitus and they need more tests to confirm. 3, we have 2-hour plasma glucose level during oral glucose tolerance test. So what does this mean? Oral glucose tolerance test is that we give the patient about 75 grams of carbohydrate or sugar or food, and then after 2 hours, we check the blood glucose level. And if it's greater than 200, it means that the patient might have the diabetes mellitus. Right, A1C. A1C is the most popular and the most used diabetic diagnostic test. So 6.5% or higher indicate diabetes. It stands for glycosylated high hemoglobin. It reflects the glucose level over the past 2-3 months. It's actually 3 months. So make sure remember that number, 3 months. Goal is for established patients who already have diabetes, the goal is for them to maintain between 6.5 to 7 to reduce the complication that diabetes can bring. Good management A1C is less than 7 and bad management of A1C is more than 8. This is specifically for the diabetes population. So how do we confirm whether a person have diabetes mellitus type 2? First, we check fasting blood glucose level. We tell them to NPO for 6 to 8 hours. If the glucose level is more than 126, we then we do another test called the casual finger stick random glucose. And if this is more than 200 ml, we do the oral glucose tolerance test, which give the patient 75 grams of carb, then recheck in 2 hours. If this is more than 200 milligrams, it confirms diabetes. So there are 3 steps, okay? Fasting blood glucose, and then random glucose, and then oral glucose tolerance test. Hypoglycemia treatment. So anything with blood sugar less than 70, this is a medical emergency. If you guys go to clinical and you guys do a a finger stick on a patient and it's less than 70, make sure to go and tell your nurse immediately because this is a medical emergency. Treatment, always remember cold and clammy gift candy. We give the patient or help the patient to consume 15 grams of simple carbohydrate. They can be either fruit juice, regular soft drink, mostly apple juice is the best, or we can directly put a glucose gels on the patient mouth, or injecting glucose into the patient IV. Next, we have diabetic ketoacidosis. So this disease is specifically target for the type 1 diabetes. The characteristic of DKA is hyperglycemia, ketosis, acidosis, dehydration, tachycardia, hypotension, hypokalemia, polyuria, and thirsty. So ketosis and acidosis is very important. It is the hallmark for DKA. This patient will produce excessive ketones because let me pause this real quick. All right. Sorry for that click. There were just some technical issues, so I'm going to continuing where I was left. So let's talk about DKA again. So it's present only in type 1 diabetes, and the hallmark for DKA is ketosis and acidosis. This patient produces a lot of ketones, and which lead to decreasing their blood pH level and lead to acidosis. Why do they produce this ketone? The reason is this diabetic patient does not have the insulin in order to convert the glucose into energy and feed the cells. Therefore, the body will use their fat to create energy and take the fat and turn it into energy for the cells to use. And when they do this, when they're using the fat, it has a byproduct, which is the ketone, which can lead to diabetic ketoacidosis, basically. So these patients will have severe dehydration, poor skin turgor, dry mucus, tachycardia, orthostatic hypotensions. Early signs include lethargy, weaknesses. Okay, those are early signs. And as progress, the skin become dry and loose, the eyes soft, sunken, nausea and vomiting, Kussmaul respiration with sweet, fruity breath odor, acetone. Blood sugar more or equal than 250, larger or equal to 250, blood pH lower than 7.30, serum bicarbonate less than 16, the regular number is 22 to 26. Moderate to high ketone levels in the urine, Kussmaul, deep, rapid breathing, body attempt to expel carbon dioxide. The goal is to prevent hypovolemic shock. Emergency management of DKA. So ensure that the patient airway and administering oxygen. Establish IV access because we begin with normal saline or half normal saline. We have to use isotonic fluid in order to prevent dehydration. So simultaneously, we start the IV insulin regular while we also infusing normal saline, okay? So remember IV insulin regular, okay? These are short acting. When blood sugar reaches 250 or lower, we change the fluid to dextro 5% to 10%, add it to normal saline or half normal saline. This is to decrease the cerebral edema, prevent fluid overload, and not to cause too rapid decrease of blood sugar. When blood sugar gets to about 200 or below, slow down the fluid and take off the insulin because we don't want to keep make the blood sugar lower. So we have to monitor potassium. This is the reason for this is because insulin will causes the potassium level to drop, which lead to hypokalemia. So because it will drop due to the administration of insulin, insulin shift potassium in the blood back into the cells, causes hypokalemia. So we have to constantly monitor the potassium level when we provide treatment for the DKA. Potassium is predominantly intracellular. Okay, that means that potassium usually stay in the cells. In DKA, these potassium leak into the patient blood, and the insulin will bring the potassium from the blood back into the cell, which can lead to hypokalemia. So we only need to have potassium chloride ready, and if we monitor the potassium level of the patient and it's get lower than 3.5, we start immediately infusing the potassium chloride to make sure that it does not fall out of range. Next, we have hyperglycemia. This is anything larger or equal to 151, okay? ABGs, you guys need to know this, arterial blood gas. So pH, normal range is 7.35 to 7.45. Carbon dioxide is 35 to 45. Bicarbonate is 22 to 26. Make sure you guys know which one is respiratory, metabolic, or acidosis. I have a video on that and I posted on YouTube already. Let me know if you guys need me to send the link again. And need to know metabolic acidosis and alkalosis. But these numbers you guys need to remember. Carbon dioxide is an acid, so the higher the number, the more acidic it causes the blood to be. Bicarbonate is a buffer, so the higher the number, the more alkaline it causes the blood to be. Okay. Bronchoscopy and thoracicoscopy. These are procedures that visualize the inside the patient lungs. The reason why I put it on here because there were questions on the HESI talking about these procedures that I remember from my last HESI. NPO for 48 hours prior to the procedure may be used to obtain biopsies, remove objects, assess airway damage, and stage cancer. Lidocaine is sprayed into back of the throat to numb gag reflex. When patient comes back, they are at risk for aspiration, numb gag reflex. No water. Nurse must take gag cough reflex before administering food. Okay, just give me 1 second. Okay, so the reason why there are no water is because these patients are at risk for aspiration. There are the lidocaine, the numbness agent is sprayed into the back of their throat so that there are tubes that can go inside the patient throat and visualize the patient lungs. Okay, and again, the nurse must check the gag and cough reflex before administering food. Thoracentesis. This is procedure where they withdraw the fluid from the lungs for biopsy. To prepare, we put the patient in tripod position, meaning like sit up and their hand like this and then bend over like this. Okay, like bend over like this. Potential complication, pneumothorax, meaning that they can puncture the lungs, collapse of the lung, diminished lung sound. Tachypnea, tracheal division, meaning the trachea deviated to a side of the throat if the lung collapse. Sputum test, this is for infection and bacteria. This is done in the morning. Okay, sputum test is used to have a culture to see if the patient is infected with what specific type of bacteria so that they can give the appropriate antibiotic. And it is done in the morning because that's when there are most secretion and most stuff. Pneumonia, infection in the lungs. Prevention is incentive spirometer. Breathing exercise, antibiotic is a priority. So basically pneumonia, it is inflammatory response. The capillary wall became very leaky. The fluid shift from the capillary to the interstitial space and then leak to the alveoli. So the alveoli is filled with like pus and fluid. Those are the best place for best environment for bacteria. The patient is basically having an infection of the lungs and a lot of fluid inside the alveoli. And you guys know the alveoli is where the gas exchange occur. And if there are too much fluid, there's no space for the gas to exchange. So they cannot get the oxygen to the body. VQ mismatch. This is poorly oxygenated blood returns to the heart, lead to arterial hypoxia. Infection to the lung, bacteria, virus. This inflammatory response, alveolar edema. So this is an inflammatory response that can lead to alveolar edema, meaning fluid swelling in the alveoli, plus exudate formation, meaning like pus and like all these porous stuff. Lead to alveoli and respiratory bronchial filled with sores, exudate, blood cells, bacteria, and fibrins. lead to consolidation of lung tissues, okay, like hardening and like stuff, lung tissues. Signs include lung sounds diminished, fever, cough, green, yellow mucus, white blood counts increase. However, this doesn't tell us they have a lung infection, even a chest rate. A positive sputum culture will confirm the pneumonia. The culture is done in the morning for more buildup. So in order to confirm, the diagnostic test for pneumonia is positive sputum culture. Okay. Next, we have tracheostomy. So trach is usually, we usually suction the trach so that the patient can breathe better, cough better, and getting air. So trach facilitates secretion removal. When assess needs for suctioning hourly, includes coughing, coarse crackle, wheezes, moist cough, agitation. Provide pre-oxygenation for at least 30 seconds. Insert without suction until the patient cough. Immediately stop suction if the patient becomes bradycardic or hypotensive, meaning that they don't respond well to the treatment. So we have to suction immediately. A dysrhythmia can occur. Stop immediately, is that what I meant? SpO2 less than 90, that's when we need to stop as well. So that's why when we suctioning the patient who have a trach, we have to make sure to put the pulse oximeter on their fingers so that we can make sure that if it go less than 90, we stop the procedure. So we wait at least 30 seconds to suction again and must be hyperoxygenated for at least 30 seconds in between section, and we only allow 3 passes of suction at a time. If not all clear, we let the patient rest and we come back at a later time. Always keep a replacement tube of equal or smaller size at bedside. Okay, we only keep ammo bag, replacement track, and suction. Next, we have tuberculosis. Okay, TB. TB will go with you guys until 4th semester. That at least I know. It will come back in pediatrics, and it's an important thing to know. But basically, TB is bacteria goes into lung and tear it up. And the bacteria that goes is the acid-fast bacilli. Please remember the name of this bacteria. It may come up on the HESI, and you guys will immediately know that it will be tuberculosis. So patient will show signs and symptoms of fatigue, malaise, night sweats, very important, chronic productive cough, hepatitis, meaning cough blood, advanced stage, pleuritic chest pain and breathing, glow rate 10. So if the patient start coughing up blood and have night sweat, the nurse should wear a mask and start isolation. Tuberculin skin testing. A positive finding is that a TB is put in the arm, a little reaction, redness and swelling will occur. If it stays swelling and bigger after 48 to 72 hours, you may have been exposed to TB. Remember the tuberculin skin testing, if it is a positive testing, it means that we may have been exposed. It does not confirm that the person is already have TB, just exposed. Okay, so the area of induration swelling size is measured. So if it's larger than 15 milliliter, it is for the general public without risk factor. If it's larger than 15 milliliter, it means that they have been exposed to the TB. If it's larger than 10 milliliter, for resident or long-term healthcare facility, IV drug abuser and healthcare worker, it means that these people have been exposed to TB. Okay, so for example, if it's 18 milliliter, it would be the person is exposed even if they are general public. Okay, but if it's 13 milliliter and they are general public with the risk factor, then they are then their test is not positive. But if it is 9 milliliter, for example, and they are HIV positive recent contact with active TB, it means that they have a positive TB test. Okay, so it's more than 5 milliliter HIV positive recent contact with active TB. I hope that makes sense. Next step is TB chest x-ray to see what's going on in the lung. This is still not confirmed that the patient have TB. The sputum for TB is what confirm whether the patient have the tuberculosis or not. We need to test for acid-fast bacilli. If this is positive, we confirm the TB. So we ask them to get the sputum from the spit, from their secretion, and then we go to test for acid-fast bacilli. And if it's positive for this bacteria, we confirm the TB diagnosis. TB patient is often put in isolation, negative pressure room until we have 3 AF acid-fast bacilli negative tests and still stay on medication 6 to 12 months, even after 3 times negative result of acid-fast bacilli. Okay, so even they have 3 times of negative result after taking medication, they still need to stay on the med for 6 to 12 months after that, after being discharged. And in order for them to be discharged, they need 3 acid-fast bacilli negative tests. All right, next we have bone marrow biopsy. So this is a procedure where they take a piece of a specimen of the bone marrow for biopsy. How to prep for these patients? In order to reduce risk for infection, it has to be a sterile procedure. We clean the area with chlorhexidine or betadine, numb the area with lidocaine, then make a cut with the scalpel, put the needle in until it reaches the bone marrow, withdraw the blood, tissues, and bone marrow. So this part is more like for the surgeon or the doctor. So basically, iliac crest and sternum at the chest is where the bone marrow is produced. It's a place of production of red blood cells, white blood cells, and platelets. So these 2 are more important to know. That's what I would take away from this slide, the iliac crest and the sternum. Biggest complication of bone marrow biopsy is bleeding. Post-procedure, we lay the patient flat on their back, okay? The back is down, it's going to be a supine position. And whichever side they have the biopsy on, for example, the right iliac crest, we'll put the leg of that side up for about 30 minutes to stop the bleeding, and we apply pressure on the wound. All right, next we have causes of anemia. So there are different causes of anemia, but anemia is an overreaching term, like a broad term for patients who have low red blood cells. So basically low red blood cell meaning anemia. So what are the causes? Include blood loss. This can be from surgery or traumatic injury. Decreased production of red blood cells, meaning the body doesn't produce enough. This can be from deficient of nutrients, iron, B12, folic acid. Kidney failing, this will cause lack of erythropoietin. So erythropoietin is a hormone that produces by the kidney, which will stimulate the bone marrow to produce more red blood cells. So it's basically a hormone produced by the adrenal gland on the kidney, stimulate the bone marrow to produce red blood cells and lead to anemic. Increased red blood cell destruction. So the body attacking itself, hemolytic anemia. So these are causes of anemia, meaning that in this case, the red blood cell is being destroyed. Autoimmune disease, hemolytic sickle cells, or the usage of medication, incompatible blood, or hemolysis. Hemolysis often occur during a blood transfusion if the patient is receiving the blood that does not match their Rh type or their blood type. So the medication for anemia is epoetin alpha, also known as Procrit. So it is given IV or sub-Q. Sign symptoms include hypertension, DVT, high risk for blood clot formation, stroke. So the reason why they have these sign symptoms is because the epoetin alpha they increases the production of red blood cells. And whenever there are an increasing the production of red blood cells, it makes the blood become thicker. It makes the blood more, the viscosity of the blood become thicker. So that's why the body have to increases the pressure. That's what leads to hypertension in order to move the blood around the body. And because it's thicker, so it's easier to clot and it's easier to form DVT. And these clots, when it's easier to form and they are formed from clots, they can lead to stroke, meaning obstructing an artery leading to the brain. Assess hemoglobin before giving. So before we giving this medication, make sure that the hemoglobin is, if it's more than 10, we do not give the drug. So we only give this medication if the hemoglobin less than 10. If the hemoglobin is more than 10, we stop the drug because the risk for blood loss, too much red blood cells, thick. Assess for blood pressure before giving. If it's more than 160/90, we hold the drug because of sign and symptom of hypertension. Iron medication, it can be enteric coated, sustained released. So remember earlier, iron play a part in producing red blood cells, and therefore, if the patient is iron deficiency, they can have anemic. They can be anemic and have anemia. So how to give the patient iron medication? We give it with orange juice or tomato juice. It's because iron thrive in the acidic environment. So we give it 1 hour before the meal on an empty stomach in an acidic environment. The higher the acidity, the better iron absorption. Liquid iron, we give it through a straw so that the teeth won't get stained. Biggest side effect, constipation. Iron will make the patient to have very, very constipated, and they become very constipated. We need to give them laxative. And also we need to teach the patient how to take it and the side effect of iron. But most importantly, know the constipation and how to give the medication. Next, neutropenia. Neutropenia is low white blood count in a nutshell. So white blood count lower than 4.5, the patient is considered neutropenia and they need to be put on neutropenic precautions. So always prevent infection in patients. So low neutrophil is part of the white blood count. It's a baby white cell that is not mature yet. So neutropenic precaution, hand hygiene, of course, no fresh fruit, no vegetable, no fruit, no fresh flowers. We need to wear mask, wash hand before going inside the patient room. No salad bars or buffet, no milkshake from fast food restaurant. We don't know how well the machine has been cleaned. This patient can have canned or frozen vegetable or fruit, only canned because it has already been pasteurized. Intervention for neutropenia. So, of course, antibiotic prophylactic for these patients, antibacterial, broad spectrum, antifungal, antiviral medication to protect for these patients. We give them something called GCSF. This is a medication. It also known as Neupogen. It is an injection to stimulate the bone marrow to produce extra white blood count to increases the white blood count. Where does the body produces the white blood count? It produces inside the bone marrow. And where did the bone marrow located? At the sternum, in front of the chest, and the iliac crest. So overstimulating can cause a lot of pain in the sternum area and chest and at the back. Must teach the patient that pain can occur. And because this medication is working, it's stimulating the sternum and the iliac crest to produce white blood count. So we have to teach these patients when they take their medication, they may feel pain, and that is normal. That is expected side effect. It is not something that we would stop the medication for. So bone pain is common side effect, okay? Patient can take Tylenol, which will help. How do we evaluate that the Neutropenia medication is working? We look at something called absolute neutrophil count. The higher the number, the healthier the patient, the stronger the patient immune system are. If white blood counts over 10, we stop this drug. If absolute neutrophil counts over 1500, we stop this drug. White blood count over 10 meaning 10,000, okay? If this is when we know the drug have worked over 10 in white blood count, over 1,500 in absolute neutrophil count. Normal eGFR, anything greater than 90. Okay, so normal eGFR is anything greater than 90. The lower the number, the worse the kidney function is. Anything less than 90 is bad. End of stage kidney disease is less than 15 and they need dialysis. So if a patient eGFE level is less than 15, they need to do dialysis 3 times or something a week to maintain their life. Signs and symptoms of end-stage kidney disease include fatigue, confused, blood pressure increase because too much fluid volume, kidneys does not filter waste or product or produce urine, edema, fluid retention, pericarditis, shortness of breath because too much fluid goes into the lung, acidosis, ammonia, odor to breath, anemia, kidney failure, no erythropoietin hormone. So if the patient having end-stage kidney disease, the kidney will not work. And if the kidney does not work, we don't produce any urine. And if we don't excrete the fluid, the urine inside our body, we will become overload and all of our system will be filled with fluid and all of the waste will be retained in the body and causes a lot of toxicity and lead to acidosis and a lot of other issues, including edema and swelling. All right, clinical manifestation of chronic kidney disease. Kidney unable to filter waste and electrolyte. This leads to retention and unable to excrete. Causes elevation of potassium will increase. So when we have a regular healthy kidney, we excreting the potassium. So when the kidney is in bad shape, the potassium will be retained and it will increase. So too high potassium can lead to cardiac dysrhythmia, which can lead to SVT, death, and stroke. Sodium will increase, chloride will increase, fluid will increase. Remember, they don't make a lot of urine. Calcium will decrease and phosphorus will increase. So patient in having chronic kidney disease, the phosphorus level usually high. And if you guys can recall, phosphorus and calcium, they have a inverse relationship. So whenever the phosphorus level is high, the calcium level will be low. Other waste product includes urea, creatine, and BUN. This level will be increased as well, which is bad. So why kidney issues causes heart to fail? This is because the fluid retained due to kidney failure, the kidney doesn't produce urine, remember? So causes the heart to enlarge and stretch out. And when the heart is enlarged and stretched out, and when it's pumped, it does not pump as effective anymore. And this will lead to heart failure. What are the drugs that can be used for this chronic kidney disease patient? So these chronic kidney disease patients will have hyperkalemia, remember? So we have to restrict the food that are high in sodium. For example, bananas, orange, collard green, kale, potato, apricot, avocado. Kxalate can also use if LASIK does not work. LASIK wastes potassium, okay? So basically, this medication will make the patient poops a lot and it pulls the potassium into the poops so that when the patient poops, it reduces the level of potassium. And dialysis also treat hyperkalemia. So talking about dialysis, again, it is used for end-stage renal disease, which is stage 5. And this means that the patient no longer producing urine. They are aid and urea. This also mean that the eGFR is less than 15. So there are 2 types of dialysis, including peritoneal dialysis and hemodialysis. Okay. All right. So let's talk about the first peritoneal dialysis. So the reason why I put dialysis in here again, I remember there were questions about this in my second HESI, in my Med-Surg II HESI. So peritoneal dialysis is insert a catheter into the peritoneal cavity. Okay, the peritoneal cavity, the cavity outside the stomach. Then they has 2 bags. One bag is dialysis solution. We give this solution to them and sit there for a certain amount of time. Then after that time, usually the doctor order dialysis solution and the dwelling time, which is the time, how long the solution will sit in the cavity. So after that, we lower the drainage bag. Okay, so there's 2 bags. Remember the solution bag, which is infusing the fluid into the peritoneal cavity, and the second bag is the drainage bag. And the drainage bag will lower than after the dwelling time that the doctor already prescribed. We lower the drainage bag, lower them down than the patient. This will lead to the fluid that sit in the belly will drain out of the bag. So this will help taking out the waste product and the excess fluid that it was put in there. What are the phases of peritoneal dialysis? So there are 3 phases of this cycle. The inflow, which is the filling time, usually 2 to 3 liters over 10 minutes. If we give them too quickly, the patient can experience fluid overload sign symptom, which can lead to depressed respiratory system, painful shortness of breath, feeling full and painful around abdomen area. And the dwelling phase is the phase usually when the solution is sitting there in the patient peritoneal cavity up to 8 hours. This depends on the doctor. Then we drain 15 to 30 minutes, depends on the patient. Monitor the patient while draining the patient. Take out too quickly can cause the blood pressure to drop, headache, tachycardia, palpitation. So if we take the fluid out so quickly, this can lead to sign symptom of hypovolemic shock. To fix this, we pick the bag up higher a little bit to slow down the rate when we drained the bag, the solution. Okay. Next, what are the complications of PD? So they can lead to infection of that actual site, leading to redness, inflammation, warm, pain, drainage, green smell. Peritonitis, infection of the peritoneum, the inside of the peritoneum. Lead to fever, pain, heart, and sweating. Biggest assessment finding for peritonitis, we looked at the dialysis fluid in the bag. So look for the color. If it smells, it may indicate that the patient is having infection. Is it clear or is it cloudy? If the patient has perspiration of the bladder, meaning like a leak of the bladder, the drainage fluid will be yellow because urine is yellow. If the patient have perspired their bowel, meaning their stomach, or the intestine, the color of the drainage bag will be brownish. If the drainage color should never be red because it indicates that the patient is bleeding. We want what color we want? We want straw-like color, pale and parched. Treat infection, give antibiotic or antibiotic cream. PD consideration. PD can be done at home. Patient assess whether the patient able to do this. Is the patient willing to do it? Are they going to be compliant? When to increase protein? when patient on peritoneal dialysis, okay? Because the dialysis procedure, it takes a lot of protein out of the body. So that's why we need to increase the protein in the diet for these patients. The second type is hemodialysis. Hemodialysis uses the vascular system to pull the blood out and give the blood back. We use either fistula or like the cervical thing, but we only need to focus about the fistula. That's like the biggest thing for hemo. So fistula, pulling out the blood, filter and put it back into the patient. Must maintain fistula site. So the care of the fistula is so important. Prevent the fistula from infected. Proper care, dressing change. If it's wet, we train the dressing. So make sure the site is working. How do we know that? We listen with a stethoscope for a bruit, and we palpate. We touch on it, we palpate on it for a thrill. I have the opportunity to touch one before, and you guys can feel the thrill, like the rush of the blood through the fistula. You got able to tell it right away. Do not do blood pressure, venipuncture, meaning IV injection, IV lines on the side of the fistula. Okay, so it is a restricted extremity. Never do those on them. Prevent clotting. These will have heparin to maintain the hepatency, the flow of it. What do we assess prior to hemodialysis? Before the start, we need to assess for blood pressure, obtain the baseline so that we can see if blood pressure is dropping too much or too high. Assess vascular assessment, is this patent? Assess TAM if they are infected. Assess weight. Purpose of hemodialysis is to trying to pull weight and fluid out of the patient. Weight is the best indicator to see if we are pulling off enough fluid. During the procedure, we do the vital sign, constantly checking pulse and blood pressure every 30 to 60 minutes. If the patient suddenly drops drastically during hemodialysis and heart rate begins to go up, it decreases the rate and how fast we are pulling the blood out. Never stop the procedure, we just slow it down, because the reason is hemodialysis is how the patient able to survive. If we stop, all of those toxin and medication, all of those toxin and waste will still remain in the side of the body. We only give normal saline or IV fluid and lower the rate in shock state, meaning the patient have a decreased blood pressure, high pulse, hypertension, hypovolemia. High pulse is the reason the body is when the body trying to compensate. Next, we have kidney transplantation. So if the dialysis does not work out, or the patient is able to find a donor or have a matching donor, and they are at end-stage kidney phase, they can do a kidney transplantation, and the care to assess whether the organ is getting rejected by the person who receiving it. We need to assess BUN and creatinine. It tells if the kidney is working. If it's rejected, the BUN and creatinine will be high, but if it's working, the BUN and creatinine will be decreasing. Giving this patient anti-rejection drug and immunodepression put the patient at high risk for infections. Okay, so the reason is that we put immunodepression is we don't want the body to attack the new organ, the donor organs. That's why we put them on immunodepression, and this will lead to an increased risk for infections. We never stop anti-rejection drug and constantly assess if the drug is at therapeutic levels. So again, then we can never stop the anti-rejection drug, the drug. They will be on this medication for life, and they take it every day. All right, let's stop a little bit. All right, benign prostate hyperplasia. So this is basically overgrowing of tissues, lead to an enlargement of the prostate gland. All right, the prostate gland is like right in front of the urethra of a male. Assessment is all about urine flow. So if the patient has interruption in the the stream, the nocturia, meaning waking up at night and to pee, hesitation before urinating, terminal dribbling, feeling can't empty completely after urinating, meaning the bladder still feel full, weak urine stream. These are the assessment, the sign, the manifestation of enlarged prostate gland, BPH. The treatment for BPH, oftenly we treat the patient with medication to relax smooth muscle and to reduce the size of the prostate. But if those are not working anymore, and cancer involved, we do something called TURP procedure. This TURP procedure actually came on the HESI, on Med-Surg II HESI for my exam. So we will do a procedure called TURP, transurethral resection of the prostate, cutting out some or get rid of the prostate. Large rod is inserted into the penis, cut through the bladder to access the prostate gland. What is the post-op care for TURP? We use a special irrigation system called three-way Foley catheter. The first line, we give the fluid constantly to irrigate the bladder. Okay, basically after the TURP procedure, after they cut the prostate out, they need to constantly irrigate it, meaning putting fluid over and pushing constant fluid over the cut side, because they don't want it to form clot, or they don't want it to bleed a lot. So they have a three-way Foley catheter. The first line, they give fluid, constantly irrigating the bladder. Reason is because it's to prevent infection, increase outflow, and help managing bleeding. These patients at risk for bleeding because we cut through their bladder. It is normal to have blood, urine and catheter after the procedure. Overall, manage bleeding. Day one post-op, biggest complication is bleeding. So again, if we allow the fluid to irrigate too quickly, the blood won't be able to coagulate and it's just getting flush. So it won't heal. If we do it too slowly, the blood in the bladder will coagulate and clots will form in the ureter, and they have to pee out that clot, will be very painful. Always monitor the drainage for the perfect color. Too dark, meaning clotting too much. Too clear, meaning irrigating too much. Pink is perfect. Pink is because bleeding is acceptable because these patients just have a cut through the bladder. Right, let's pause a little bit. Okay, next we have type of immunity. The first type is innate immunity. This is present at birth. The first line defense against pathogen. Normally, we don't have a lot of innate immunity at birth since we weren't exposed to many things. So these are like for the infant who was just born, he will have some immunity or she will have some immunity, and they are called innate immunity because it's present at birth. Maybe during receiving from the mom during birth, but we don't have a lot of them because they haven't been exposed to a lot of diseases or people, so they don't have a lot of immunity yet. Acquired immunity is developed the immunity. It can be active or passive. It can be natural or artificial, and we will explain that in the next slide. Natural active. Natural context, meaning you got chickenpox, measles, or mumps, an actual infection. That means that natural active. You're naturally exposed to those bacteria and viruses, and then you actually develop an infection. Natural passive is that the mother is giving it to the child at birth. Natural immunoglobulins that mothers has and pass on to the child via birth. What is immunoglobulin? Immunoglobulin, also known as antibodies. Artificial active, getting an actual immunization, meaning getting a vaccine for chickenpox, vaccine for measles or mumps antigens. These vaccine will initiate a response in the body so that the body will create their own antibody. So that is why it is artificial active, because it's a vaccine and it's the body create their own antibody. That's why it's artificial active. Artificial passive is that it's also an external injections of a serum with antibody from a person. Antibodies. For example, getting a hepatitis B immunoglobulin. Immunoglobulin meaning antibody, okay? Difference between these two is an injection, either active antigen or passive antibody immunoglobulin. Next, we have osteomyelitis. So itis meaning it's an infection. So osteomyelitis, basically it's just a bone infection. Infection of the bone, antibiotic therapy. So this is what you guys need to take away and remember. Osteomyelitis, the only treatment is IV antibiotic, and it is used for a long time. It can be used, it needs to be used up to 4 to 6 weeks. And vancomycin is toxic and it can kill the patient kidney. Okay, but they need to use vancomycin for osteomyelitis because it is the only antibiotic that can help with this disease. This vancomycin can shut the patient kidney down. Make sure when patient on vancomycin, we do peak and trough level. This tells us if there's too much medication in the patient blood. So remember, in Med-Surg II, we learned about intrarenal injury. So vancomycin is one of them. It's an enzyme, so it causes directly damage to the kidney. So yeah, it's a really bad antibiotic, but it's the only one that they can be used IV for the osteomyelitis patients. Okay. Next, we have osteoarthritis. This gets worse over time. Osteomyelitis basically are large joints. They have back, hip, and pelvis. So these are the pain that in the back, the hip, and the pelvis, the larger joints. The finger is the small joints. These are small joints, but the back, the hip, and the pelvis are the large one. These patients will have stiffness and the pain will get worse as you use it. So it's different with rheumatoid arthritis. Osteoarthritis, the more they use it, the worse the pain gets, more painful over time. Whereas in rheumatoid arthritis, this is an autoimmune. So whenever you guys hear something about autoimmune, immediately think of the body attacking itself. The swelling in the hand, in the joints, and in feet. It's usually symmetrical, meaning that if it happened on this hand, it will also happen on this hand. It affects smaller joints, the hands, the feet, the finger, the toes, and the wrist. Drug for rheumatoid arthritis are usually corticosteroids. This is used in the beginning or when the patient has an exacerbation. Okay, so remember that, please. It's going to be used in the beginning only. And whenever the patient have exacerbation, it's used only for a limited time because corticosteroid have so much side effect. They cannot take corticosteroid for a long term, because when they take corticosteroid for a long term, they can have a weight gain. They can have corticosteroid also suppress the immune system and causes issues with blood sugar, decreased wound healing, and increased risk for infection. So that's why they only use at the beginning and whenever the patient have an exacerbation episode of rheumatoid arthritis. It also can cause osteopenia, meaning bone loss. Also used in an adrenal system. This can cause kidney complication. So we never ever stop the steroid or corticosteroid medication abruptly because it can cause kidney failure. Then we go to methotrexate. Methotrexate used most common in early form of rheumatoid arthritis. It is a chemotherapeutic agent. It can cause issues with the bone marrow, make it not function very well. These patients will have low white blood count, higher risk for infection, anemia, suppressed bone marrow for patient on methotrexate, also cause platelet to drop, at risk for bleeding. So after we use corticosteroid, we move the patient to methotrexate, and this is a chemotherapeutic medication. So it have a lot of side effect, repressing the white blood count red blood cells and platelet. So we have to closely monitor for complete blood count whenever the patient on methotrexate, because it put the patient at risk for infection, anemia, and bleeding. Next, we have compartment syndrome. Basically, it is swelling and increased pressure within a limited space, okay? So for example, the patient broke the arm having a fracture, they have a cast. The person who put the cast on too tight that the skin, or the patient have an injury inside the cast, it causes swelling and the skin and the blood vessels started to expand and dilate, and there's no space because the cast is constricting the extremity. This patient can have compartment syndrome, and anything distally to the compartment syndrome, meaning anything like if the compartment syndrome happened right here at my wrist, anything in my finger will not being perfused. They will not receive any oxygen, any nutrients, any blood at all. So we have to do constant assessment for neurovascular system. So how do we do this? We look at the 6 P's. Clinical manifestation, the 6 P include pain, pressure, paresthesia, meaning numbness and tingling, pallor, meaning pale, blue, paralysis, and pulselessness. Capillary refill, we check the pulses, weak or strong. Temperature, if the patient not getting blood flow, no circulation, cold. Compartment syndrome continue. So it is best to know early to late. Early signs are pain and paresthesias. Relieving the source of pressure may prevent progressions. Late signs include pulselessness, can't even move, paralysis, may require ambulation. For patient who has a cast and having sign of compartment syndrome, get the cast cut off, but have someone more knowledgeable to do it. If the patient is in bug traction, they also at risk for compartment syndrome. Loosen the strap on the bug traction boot, don't reduce the traction. Compartment syndrome can happen even there's no cast, no bug traction. It can happen in confined space in our skin, for example, wearing a very tight jeans. Fasciotomy is a procedure where they cut the skin open to allow the circulation to happen. Skin being cut and large suture to allow confined space to open up for circulation to occur. With compartment syndrome, there is nothing the nurse can do. First priority, if we suspect a patient in compartment syndrome, is to call the doctor. Chronic neurological problems. All right, these are seizures, nursing action to maintain safeties for active seizure for patient for at risk for seizures. Okay, so remove harmful objects, bed lowest in the position, turn the patient on to the side to prevent aspiration. Patient on seizure medication, never abruptly stop. Sometimes doctor will slowly take the patient off the medication to evaluate if they still have seizure or not, the bed in the lowest position. Ultimately, when the patient having a seizure, we need to make sure they are getting oxygenated and be safe. The medication that is given to active seizure patient this include lorazepam, Ativan. This help control the activity seizure. The doctor will start with the lowest dose of the seizure meds as much as possible. Then they will measure how many seizures the patient has in a week. Then they will adjust the dose. So these lorazepam is very toxic for the body. So what they need is they need to do lab value every 6 months to make sure they are not getting too much drugs. Multiple sclerosis, MS. So the patho is damage to the myelin sheath. A no trigger stimulate immune system to attack the myelin sheath of the nerve. This is autoimmune disease. So it is immune system triggered, lead to inflammatory response that lead to myelin sheath damage, lead to scar formation, and lead to nerve impulse interruption. The assessment include muscle spasm, weakness, paralysis, paresthesia, dysphagia, double vision, diplopia. Drugs, there's no cure for MS. Steroids, immunosuppression, immunomodulators in med sheets. Don't worry about that. Diet, we need to give this MS patient a high protein diet to help rebuild the antibody, because this is autoimmune and the antibody attacking the myelin sheath. So they not only lose or damage the myelin sheath, they also loses the antibody. So that's why we have to put them on a high protein diet to regain the antibody that they've used and to heal the body. B12 to help with anemia as well. Parkinson's disease. So basically, Parkinson's disease is the problem with dopamine and production of dopamine. This patient doesn't have enough dopamine. They have a decreased level of dopamine. And the key assessment finding is slow initiation of movements, include bradykinesias, tremors, short shuffling steps, stoop posture, mask-like facial expression, no emotion, rigidity, and poor swallowing. Medication to give for these patients. Oh, I forget to say. The hallmark for Parkinson's disease is the bradykinesia and the mask-like expression. Whenever you guys see that, we will be able to tell it is Parkinson's disease if it come up on the exam. Medication for Parkinson's disease, we give them dopamine, obviously, because they have a decreased level of dopamine. Most common med is levodopa, aka Sinenet. It helps with the lack of dopamine that the patient has. Diet for Parkinson's disease include low protein diet. It intervenes with the levodopa. A loss of protein does not allow the med to absorb in the body. Okay, so for MS patient, we need to have a high protein diet, whereas in Parkinson's disease patient, they need to have a low protein diet because the medication they take is having a contraindicated or a drug interaction with the protein. Patient also not able to chew, swallow very well, so we have to make sure the food are soft, cut up, and small meals and frequent. GBS. So GBS is also known as ground to brain. I'm sorry, I spelled the brain wrong. I'm probably tired. But it ground to brain, okay? Not brain paralysis. Neurological demyelination of motor neurons, which control muscle movements. Progressive weakening from the feet to the brain. GBS will have a weakness in lower extremities, then disease move up to the bladder area, cause incontinence, then move to the colon area, constipation, then get to the lung. They can't move the lung anymore, so this patient will have no breathing and they require ventilation. So luckily, GBS is reversible. It comes and goes away. It starts paralysis from the ground to the brain, but when it goes away, it goes from the brain down. So it goes in a reverse order when it's affecting the patient. We must put them on ventilator, and when reaches the bladder, because after the bladder, it will cause a respiratory failure. Virus is often the cause of this to happen. Medication, immunoglobulins, antibody, they improve immune system response to fight the cause for this. Plasmapheresis, don't worry about it. Diagnosis, CSF will have a lot of white blood count in it. CSF is inflamed. Usually after treatment, it brings this white blood count down. Okay, so the medication for GBS, because GBS is an autoimmune disease also, so we give them the antibody to improve the immune system in order to fight GBS. because GBS is caused by a virus. Please remember that. All right, next we have stroke protocol. When there a stroke alert in the hospital, the CT scan room is cleared out immediately so that we can get diagnostic on the patient. The reason why we need the CT scan room out immediately, because we want to know whether the patient have a hemogenic shock or they have a regular shock. So first, be aware of symptom onset time. CT scan within 45 minutes, lab and EKG done within 45 minutes. Evaluate and administer TPA. TPA is a thrombolytic. It is an anticoagulant that used in the patient who have stroke. If the criteria met. MPO until swallow evaluation done. Stroke can cause dysphagia. That's why they have to be on MPO. The onset time is important because it determines the usage of TPA, the anticoagulant, which is the thrombolytic that I was talking about. So TPA, if the patient have an ischemic stroke, that's what I was referring to earlier. So the CT scan is used to determine whether the patient have ischemic stroke or hemogenic stroke. If the patient have hemogenic stroke, we do not give them TPA. We will evaluate to give TPA. The only one that actually breaks down the clot is TPA because it is thrombolytic. It breaks the clots down. Must make assessment before administering the drug. Inclusion criteria, ischemic stroke onset within 3 hours. If it's outside 3 hours, we do not give the TPA. CT confirm the ischemic stroke, measurable deficit on, don't worry about it. Over 18, if they met all of these, give the drug. So what are the exclusion criteria? Meaning if they have these exclusion criteria, we do not give them the med. If they're minor and the clot, if the clot is minor, that's what I mean, rapidly improve, we will not work. It will not work. Patient had seizure or onset of stroke. Patient's systolic blood pressure is more than 185. This increased risk for hemorrhagic bleed if we give them the anticoagulant. Patient, this diastolic blood pressure is more than 110, the same reason. Lab, patient received heparin within the last 48 hours and has an elevated PTT. We also do not give the patient this med. PT time more than 15 seconds, do not give this med. Platelet is less than 100,000, do not give this med. And glucose less than 50 or more than 400. Patient has another stroke within the past 3 months. Major surgery within the 14 days, all of this, we do not give TPA if the patient have any of this. All right, so lastly, the last chapter, my favorite chapter is endocrine. So basically, we have to know the pituitary gland. The pituitary gland is the master gland. They have the anterior pituitary and the posterior pituitary. So anteriorly, the one of the disease that they cover in the HESI is the growth hormone, excessively releasing of growth hormone. So too much secretion of the growth hormone, we will get big people and giants. Acromegaly, these people will have big jaws and hands. So these big jaws are facial structure that are huge and loss of bone structure. These can cut off the patient airway or impair it. So the focus assessment for these patients are airway, make sure the patient get good oxygen. Too much growth hormone causes hypertension. The heart gets very big, CHF, heart has to work harder, joint pain and visual issues. So the treatment for the growth hormone assets, we put a large endoscope into the nose and cut the back of the mouth to access the brain and then take out the overfunction part of the pituitary gland. So the pituitary gland, the part that releasing the growth hormone excessively, we go through the mouth and cut through the mouth and access the brain from there and then cut the pituitary out. So the post-op for these patients is very important. Biggest issue is aspiration. Patient can be bleeding, so basically they can choke or drown on their own blood. or aspirated on their own blood. Tissue swell up can cut off the airway. So we need to look at the neuro. We need to check whether the LC is okay. Are they waking up, answering appropriate question? We need to done Q4 hours. Raise head of bed 30 to 45 degrees to decrease the swelling in the head. Monitor any type of drainage coming from the nose. Is there any? We use nasal swab to collect and see if there's any glucose. When it's dry, when it will be crystallized. No deep breathing, no cough, no sneezing or straining because it can cause increased pressure and cause dehiscence. Okay, this patient is not MPO, but they need chopped food, very thin or boost, because if they do eat, we must do very good oral care because if not, they can cause infection in the wound. Please remember the wound is at the back of the mouth. So anything infection or any inflammation can cut off their airway. And the reason why they need small food because they don't want large food to have an impact or injure the wound. Next, posterior pituitary gland. So posterior pituitary gland only release 2 hormones. Please stick this into your mind. It will come up in pediatric again. I just have an exam. It's released 2 hormone, ADH, antidiuretic hormone, and oxytocin. ADH also known as vasopressin. So depends on the type of the hormone that is abnormally released. It causes different disease process. Okay, so SIADH and diabetes insipidus. SIADH is basically too much secretion of aldosterone. No, I'm sorry. SIADH is too much secretion of antidiuretic hormone, meaning that the patient will retain the water. So risk factor, put the patient at risk for this happen is tumor, pneumonia, tuberculosis, infection, medication, adrenal insufficiencies. SIDH is all about fluid volume overload, too much water. Fluid restriction, 800 to 1000 milliliter a day. Reduce the fluid intake. These patients so thirsty, but we cannot give them a lot of water because they are already overload. Their ADH hormone is so much that they retain all of the water and they don't pee. Mouth care, sponge, that's how we treat when the patient is thirsty. We give this patient diuretic to pull off the excess fluid. This patient can have hyponatremia. They have hyponatremia is because they retain so much water in the body. So the level of sodium compared to the level of the water is so low. So they have hyponatremia. Look at the lab, specific urine gravity. Are they able to concentrate the urine? Urine decrease, specific urine will increase. Increased specific urine gravity means more concentrated, and low specific urine means diluted. So this patient will have a high increased specific urine gravity, okay? Because their urine will be very concentrated. They retain all of the water in the body. They don't produce urine. And if they produce urine, this urine will be very little or concentrated, very yellow and dark, tea colored. Okay, so assess the heart and lung sound, crackle in the lungs, murmur or extra sound the heart because they are overload fluid. Seizure precaution due to too much fluid retention, head of bed, no more than 10 degrees. Blood pressure will be high due to high amount of fluid retained. Goal, try to avoid fluid or volume overload. Sign symptoms include edema, weight gain, crackle in the lungs. Treatment, fluid restriction, diuretic, do not restrict sodium because the patient already have hyponatremia. All right, for diabetes insipidus, hyposecretion of ADH by the posterior pituitary gland. Basically, they don't produce enough ADH, so they don't retain water. They keep peeing, and they don't retain any water in the body. So DI means not enough water. Patient will show signs symptom of dehydration, polydipsia, low specific gravity, large quantity of urine, excess thirst, dehydration, electrolyte imbalances. Potential complication is trying to avoid dehydration, hypovolemic shock, sign symptom polyuria, dry mucus, foreskin turgor. Check at the sternum, decreased blood pressure, hypovolemic shock, high heart rate, try to compensate, polydipsia, very thirsty. Irritable, mental status, mental sluggishness and coma, hypotension, because they're peeing out all of the volume, okay? So they don't have a lot of volume in the body. So that's why they have hypotension. High heart rate, which is classic sign symptom of hypovolemic shock. Treatment, give fluid, normal saline, lactated ringer. DI look like patient going to DKA. Next, we have thyroid gland. Thyroid gland regulate metabolism. So we look at the TSH level, T3, T4, calcitonin. Parathyroid regulate calcium and phosphorus. So T3 and T4 always together. TSH and T3 and T4, they have an inverse relationship. When TSH is elevated, T3 and T4 will be decreased. So what does this mean? So this means that if the patient having an elevated TSH, that means that they have hypothyroidism. If the patient have an decreased TSH level, like a very low TSH level, they can have something called hyperthyroidism, hyperthyroidism, okay? This is because TSH has an inverse relationship with T3 and T4. So T3 and T4 is what the thyroid actually secretes. The more T3 and T4 they secrete, that means that they have hyperthyroidism. The lower they secrete, that means that they have hypo. Normal thyroid is euthyroid. Thyroid work perfectly. That's what that means. Okay, so let's talk about hyperthyroidism and hypothyroidism. Hyperthyroidism, basically, if not treated, will lead to thyrotoxical, aka thyroid storm. They can have hypersecretion of T3 and T4. TSH for these patients will always be low because T3 and T4 are high. Assessment, they have increased basal metabolic rate, everything fast. So basically, they have high metabolism, tachycardia, heat intolerance, exophthalmos, like the bulging eye, issue with maintaining weight. They eat so much, but they lost their weight. They need 5,000 calories a day. They can have a goiter because the thyroid became too big, or diarrhea. How to treat them? We can take the thyroid out because it is producing too much thyroid hormone, and the thyroid at the neck, which also include the thyroid, which can be done through a procedure called thyroidectomy. It cut the neck open and remove the thyroid. Since we take out thyroid, we need to monitor for hypoglycemia. Side of symptom calcium is tetany, spasm. Calories must reduce and lower since metabolism will be decreased. Place the patient in low flower position, assess for hemorrhage, monitor calcium level, assess for tetany. Hypothyroidism, if not treated, will lead to mixed edema, coma. Okay, assessment, low heart rate, always feel cold, they have low metabolism, they can gain weight easily, nails are fragile, brittles, losing hair, facial eyelid edema, they have a edema on the face, thick tongue, so it causes slow speech, constipation. Late manifestation include bradycardia, weight gain, decreased LLC, thickened skin, cardiac complication. So basically, there's nothing that we can teach them to make the thyroid work apart from teach them how to take the medication. So these patients basically don't produce enough hormone, and they need to take the levothyroxine, the medication forever, every day. So the medication for hypothyroidism is levothyroxines. They basically helping the thyroid to produce more thyroid hormone, T3 and T4. Common side effects, insomnia and weight loss. If patient complains of these, do not stop the medication because these are normal common side symptoms. Serious signs symptoms include hypertension, tachycardia, cardiovascular collapse. If patient complains of these, palpitation, high blood pressure, headache, the doctor will decrease the medication but not stop it because we need this medication forever. But this current dose that the patient is getting is a little too much. Okay, hypocalcemia psi. This side including trozosi. This trozosi is the side where they put the cup, pleasure cup on the hand, and then the hand kind of like this. Yeah. Shovtech side is when they touch on the face and then they have like a smacking, like a reflex to it. That indicate hypocalcemia, low calcium level. They have diarrhea, tinkling around the mouth, low magnesium. Calcium, magnesium are best friend. That means that calcium increase, magnesium will increase due to thyroidectomy. All right, let me take a break. Okay, so the adrenal gland disorder. So kidney is related to adrenal gland. Adrenal gland located directly above the kidney, basically. So there are two disease, addition disease and Cushing disease. Addition disease is hyposecretion, not secrete enough and need to add in. So they need more cortisol. Cushing disease, hypersecretion, fluid volume overload, look like cushions. These patients will be like very overload with the amount of cortisol that they secrete. So they look like a cushion. Adrenal gland regulates sugar, salt, and sex. So if it does not functioning, the sugar will go up, the salt will go up, and they will have a decreased libido. Cushing and addiction disease are all about steroids, meaning corticosteroids, meaning cortisol. Okay, so Cushing disease, hypersecretion, so adrenal gland functioning too much. This patient will have high blood sugars, high sodium contents, very puffy. They make the bone weak because remember, corticosteroid can cause osteo something, I don't remember, but it causes the bone to break and weak easily. It suppresses the immune systems as well. So the patient will have moon face, big trunk, but extremity is very thin and small. They thin, frail, purple striae and bruises. Big risk factor for Cushing disease is chronic steroid use, like they are constantly using prednisone or medication that are steroid. They work in the adrenal gland, which make the adrenal gland work too much, will lead to Cushing syndrome. This patient has high risk for fluid volume access, monitor for vital sign, electrolyte, especially lower potassium level, glucose level. A patient with Cushing disease will have Cushing syndrome will have hypertension, fluid volume access, edema, petechiae, bruising, steroid high, big round hairy. They'll have big blood pressure, big glucose, big sodium, big trunk, big face, big buffalo hum, big hair, meaning a lot. They'll have hirsutism, big stretch mark, purple striae, big infection, slow wound healing, and big weight, meaning they gain a lot of weight because the cortisol increases the blood sugar. Next, we have hyposecretion, meaning addition disease. So this patient with addition disease, they don't secrete enough of the cortisol hormone. They don't have enough of the hormone, so the blood sugar gonna be low, potassium level gonna be high. This patient will have anorexia, nausea, decreased bowel sound, low blood pressure, tan, bronze skin, monitor for INO and daily weight. We want to give them aldosterone to increase that and peeing 2 liters a day. So basically, patient who addition disease, they don't produce cortisol and they don't produce aldosterone. Aldosterone is a hormone that increases the sodium level, retaining the sodium, therefore retaining the fluid. So this patient does not produce aldosterone, so they don't retain the fluid in the body, okay? So they pee like 2 liters a day, and then they can go to crisis, something called like additional crisis, Addisonian crisis. that can lead to hypovolemic shock, cardiovascular collapse, severe hypotension. We treat it like a shock, absence of steroid, low, small, weak, tan. These are their sign and symptom. Low blood pressure, low weight, low temperature, low hair, meaning alopecia, low mood, depression, low sodium, hyponatremia, low glucose. Too high pigmentation will lead to bronze, too much potassium, hyperpigmentation, and hyperpotassium, high potassium, high hyperthermia. All right, so that is the end of our session today. This covered basically the things that you guys need to know for Med-Surg I to be better prepared for the HESI for Med-Surg II. Obviously, again, I cannot cover everything, but those are the things that I think really important for us to know, for you guys to know. So I thank you for everyone who make it into the end, and I hope it was helpful, and I wish you all the best of luck. I will post the HESI, the Med-Surg II content on November 30th, so that you guys can look at it and study, and also post practice question for you guys. Thank you so much, and I'll see you all later.